السلام عليكم دكتور عمر.
Walaikum salam.
How are you?
I'm good. How are you doing?
Alhamdulillah. So Ramadan Mubarak for everyone. We're gonna start now. So in the beginning of this meeting, till now we have like 28 participants, and we gonna start about the experience of COVID-19 in New York. And I'm gonna start with one of the chief residents in Mount Sinai, Dr. Omar Saleem. So you can start now, Dr. Omar, and tell us how are you doing during the COVID-19 era, and tell us what's your experience, because till now in Egypt we have only almost like 3,000 cases, and till now only few hospitals are limited to admitting COVID-19 patients. So not all the physicians have experience with COVID-19. So what I need you to tell us your experience, because Queen's Hospital was one of the hospitals that was devastated by the COVID-19 pandemic. So you can start now and tell us what do you think.
Sure. I think that's a good place to start. Yeah, it's actually been an amazing 2 months, 3 months almost, since this pandemic started. Initially, when we heard cases in China, we were thinking, logistically, because we have a big Chinese population here, especially near where we are in Queen's Hospital Center. We're in Flushing, and the border of Flushing and Jamaica, and that borders a very big, probably the biggest Chinese population in New York City. So when it was about February, we started having our first case. We had a patient who came in with symptoms, possibly travel history, and then we started exploring the idea of possible coronavirus infection. And then late February, we started having patients that came in that had no travel history. And that's when we started seeing the cases in Washington State. And when we heard about that, then we started to bring up COVID in our differential. And these patients would show up in a very similar pattern, which I'll go through in a little bit. And as that started happening, all of a sudden, within maybe a week, initially, our plan, going forward, we were thinking, okay, maybe we'll see a few more cases and we'll have a separate unit that we can build for COVID patients. But all of a sudden, within a week, we started having almost 95, 98% of patients, only COVID patients that would come in. And we were almost not seeing anything else. So beginning of March is when that really hit. And what we call the surge started at that time. And at that point, we started seeing admissions of almost 50 to 60 patients a day total. I think in Queen's Hospital, we've had almost 3,000 cases just within the past 2 months. And within the whole NYC health and hospital system, we've had almost 28,000 cases of COVID that are positive and that were tested. There's some logistical issues we've had that we can go about later on, but one of the issues we had was testing. And because of this lack of testing, we were only testing patients we were admitting. We were not testing patients who came in with presenting symptoms. So likely our cases are almost double, if not triple. But the only tested admitted patients, and almost all of them, we had about 2,900 in Queen's Hospital in the past 2 months. So we peaked, I believe we peaked about 2 weeks ago. Initially our floors and our wards are what peaked. Basically we had almost about 250 patients on the floors. And then slowly, it was almost like a 1 week lag where we had a peak in our ICU. So our ICU followed with almost I would say almost a 5 times increase in our capacity, where we had patients everywhere in the hospital that were intubated, and just the progression of the disease led to not just a prolonged hospital stay, but also a prolonged ICU course where they were intubated for a long time. And we're seeing that once they are intubated, their prognosis is very grave and very poor. So now over the past 1 week or so, we've seen that surge decline. I think we've hit the apex here. And it seems like it's slowed down. The social distancing measures seem to have helped, but at the same time now, I think there's this false sense of security that's coming in to the city here. So we're seeing more people outside, more people walking. So we're expecting possibly another a micro surge of patients that come in. So that's basically how it's been. I think the trajectory over the past 2-3 months.
Okay.
Yeah. Sure. Go ahead.
So that's your experience regarding the epidemiology. But you know what? The doctors also need your experience. You were on the ICU or on the floors in the past 1 month?
I was in the ICU. Sorry,
Okay.
I was in the ICU for a few weeks, but I was also on the floors most of the time.
Okay, so I need you to tell us about the experience for 2 patients, because that's where the people lack the knowledge. First, I need how the patients enter the ICU if they were directly admitted from the ED. Second, what happens when the team calls for an ICU consult. Third, when there is an RRT and patient will be directly admitted from the floor. Tell us about the prognosis, what you used to do, and how to manage such cases.
Okay, so I think for the ICU, I'll leave this to Dr. Osman. He has been on the ICU the whole time that this has been happening, so he's probably the best person to talk to about that. For as far as the floor, I can elaborate on that definitely. So most of these patients, when they come are admitted, that are likely to be admitted to the floor, they're presenting complaints very significantly. I think one of the things about this disease is that there are certain common traits, and there's also certain like it's a big wide net that they vary within. So probably the most common presenting complaint is fevers, and normally their course is about 3 to 4 days is when they get very symptomatic with their fevers. That's usually very rarely do they present with a day or two of complaints. It's mostly on the 4th or 5th day that they present. And so most commonly, I believe, is fever, and then cough, and also GI symptoms. So a lot of them have loss of appetite. A lot of them have vomiting that they have. And this was something that initially we didn't really register, but after you see them more and more, that's something that's happened. The other interesting thing is, I know here the American Society of ENT, they had declared that anosmia was a possible complaint, and I think that's something we have seen. And even amongst our personnel who have been infected, they have complained of that as well. So all of those things happen. So they come into the emergency room. When they come into the ED, they are the majority of them are saturating in the low 90s. The ones we normally admit to the floor, they usually start saturating in about the mid 80s to low 90s, improve on oxygen. And our criteria for admission is people requiring oxygen saturating above 94% after supplemental oxygen. So this can be either nasal cannula, this can be non-rebreather. For initially, when we started seeing patients, we were avoiding anything that was nebulizing. Even now, we tend to avoid them, but we stayed away from CPAP and BiPAP for non-invasive positive pressure ventilation. And this was because of aerosolization and things like that. But as we moved on, and as Dr. Osman might elaborate more, we're trying to prevent intubation to as late as we can. So we started utilizing the BiPAP and the CPAP. And I think that's led to a few patients that have improved. But at the same time, I think he would be better to talk about how they progress later on after that. So normally on their chest x-rays and imaging, you see the phenomenon of the bilateral patchy infiltrates, and it's a very distinct picture. They can vary as far as how the grade is. Some are significant infiltrates, some have mild infiltrates, but usually that bilateral patchy infiltrate picture is what is most common. On CT, it's the ground glass opacities, and that's normally what we see, though we have been avoiding doing any kind of contrast CTs just because of the labs. And as far as the labs go, so usually these patients have an element of AKI. They have transaminitis with elevated ALT, ALP, AST, and they can vary sometimes in terms of their electrolytes. We've seen many patients come in with hypernatremia, and usually that tends to be in the more elderly population. So it is a varied picture, but at the same time, so these patients, normally the ones we admit, are the three categories I would describe them are the ones who are hypoxic, requiring supplemental oxygen, and they usually have lab abnormalities like AKI, transaminitis, and things like that. So now once they're admitted, our treatment regimen for them is, on top of the oxygen, is hydroxychloroquine with azithromycin. Now, based on QT, we go with one or both, and then if QT is slightly prolonged, we still do one. We would still do hydroxychloroquine likely, and then they would get about a 5-day regimen. We started implementing tocilizumab for admitted patients that qualified and fit the criteria for it. So these were patients usually who are not on immunosuppressants, who qualify with age, and have prognosis that's more than 2 days. So those patients would receive tocilizumab, and we saw many patients who had an improved inflammatory response, where their CRP would drop significantly, and many of them had improvement in their respiratory requirements too. So then once they're admitted, and we basically on a daily basis monitor their saturation. The saturation is probably the one method that we use to monitor them and decide as far as how their course would be. We on a daily basis maybe check their saturation 4 to 5 times and titrate it down, usually pretty aggressively. The issue is that most of these patients tend to require almost 7 to 8 days of hospitalization. Our average course of hospitalization was about 7 to 8 days for these patients. And then they would be discharged after that. Some patients we were discharging on supplemental oxygen, about 2 liters if they were able to, otherwise they would be discharged home on room air if possible.
Okay. And tell us, like, can you elaborate on like daily labs? Tell us like what you order every day, how do you start tocilizumab, whether you use the H score or use the IL-6. Tell us about the details, because that's what we really need. That's where the knowledge gap is.
Sure. So as far as the labs go, so all patients who we admit, we do a full set of labs. These include D-dimer, CRP, ESR, the IL-6 levels just initially, and as well as we are also doing an anticoagulant profile. These include cardiolipin, beta-2 glycoprotein, lupus anticoagulant, and protein C, protein S, anti-thrombin 3. And then on top of this, we also check their fibrinogen level. And so this is what we do on admission. Now, once we have these set of labs, they have received IL-6. What we monitor is their D-dimer and their CRP. And the D-dimer has probably been our best prognostic indicator, anecdotally. Also, I think I'll touch base with the anticoagulants in a bit. But as far as trending labs on a daily basis, D-dimer and CRP are probably the 2 that we trend on a daily basis, along with the BMP just for renal function, because a lot of them come in with AKIs. So usually CRP and D-dimer, once it goes down, those patients, even on their clinical picture is also much better. Now, as far as the anticoagulants or the labs for that. So when a patient comes in, initially when we were getting patients and they would come in with elevated D-dimers, we were attributing this to their in the setting of the sepsis, or in the setting of their infection, things like that. But slowly we saw that when we would do either CTA scans on some of them who were significantly shorter blood or significantly hypoxic, and even with mildly elevated D-dimer, we would find pulmonary embolisms. And so Mount Sinai came up with a protocol. Essentially what we started doing was anyone who was requiring excessive oxygen, anyone who had elevated D-dimers more than 5 times the upper limit, and or anybody who was significantly septic, we would start on anticoagulation on admission. This was either done with a direct 10A inhibitor, either apixaban or rivaroxaban, or we would preferably use Lovenox, enoxaparin, and if they were admitted to ICU, they were using heparin, I believe. Now, we had this was done based on anecdotal data and also based on some studies that had come out of China. And so anyone with that elevated D-dimer, we would trend the D-dimer every day, and we saw significant drops in the D-dimer and also significant improvement in those patients. So that was the reason we would do the anticoagulant workup or the coagulopathy workup in the beginning, just to have an idea for those patients. Now, those whose renal functions were good, we would do imaging studies on them just to rule out pulmonary embolism. So then we would have a treatment regimen for discharge. But most of them, because of the AKI, they would be treated, and they would be treated with anticoagulation and then discharged on the home.
Okay, and regarding the ferritin, because I see questions about the ferritin, do you do the ferritin daily?
The ferritin, we do it on admission, not daily though. We don't use it trend it as much. The D-dimer CRP is what we mostly trend.
Okay.
I think. Yeah.
And regarding the infection control, so I know that few of your friends already were infected by COVID. So tell us how you feel safe and what do you think the mistake that they did and they got infected?
I think that's also very true. I believe our personnel infection rate is almost 30%. So, and the reason probably is because we wear proper PPE going into patient rooms. So this includes eye protection with goggles. This includes an N95 mask for aerosol protection, and also contact precautions. But the issue is, one, I believe the issue is taking care of that PPE once you're outside the room. The contact, we have disposable gowns, but the masks, sometimes we have to keep wearing them, and taking those masks from room to room, or going back to either the doctor's lounge or going anywhere else with those masks can carry over the particles to other people. The other thing is, I believe there is a sense of safety amongst personnel. So say we're within our room or within talking to each other in a closed environment, I think you still have to abide by at least wearing a surgical mask, because I think the issue is also the lag time between a symptomatic person and the viral shedding. I think that played a big role as to people not being wary of who's infected. And so you would have interaction without any surgical mask, and that would then cause the other person, because we saw a lot of people the ones who were getting sick amongst those people who they spoke to. So it would happen it was very interesting. We would have certain teams where our teams are either 2 residents and 2 interns, and you would see one person get sick, then the other intern would get sick, and then the resident would get sick. So it's the whole team would end up being sick. And it was very fascinating how that would happen.
So when the whole team will get sick, you mean that they were exposed, for example, and they were not using protection, or they were some like patients that are super infectious?
I believe it's both, because we've had both cases. I think the super infectious patient is a very interesting phenomenon, because there have been, and the severity of illness for those people who got infected with that same, who are on the same team, was very comparable. We had one team where one person got sick. They were very sick, very febrile, very hypoxic, and the other person who got sick with them was also very febrile, very hypoxic. Whereas there's another team actually who was not as sick, and the rest of the team was not as severely sick either. So I believe there's an element of that in there.
Okay, so we have a phenomenon in infectious disease called super spreaders. That's the patient that can spread the disease actually more than the others. So I will make you on hold like a little bit, Omar, and then I will ask Dr. Mohanad for a few questions, and then I will turn back to you again. So Dr. Mohanad, please, I need you to tell me about the atypical presentations that people may miss. What are the other presentations apart from just getting fevers, pulmonary symptoms, and hypoxia and all that?
Okay. Hello, everyone. I'm Mohanad Elfishawi. I'm one of the medicine chief residents also in Queen's Hospital. I work with Omar and Alaa. So the key part in COVID management is that each patient is actually a different patient. So if you make a template for the management of COVID, you might miss a lot of presentations because this virus, nobody knows exactly what's going on. So it can affect multiple organs, and each organ will manifest differently. So beside the pulmonary symptoms, the cough, fever, and shortness of breath, and the nausea that Omar mentioned, the patient can present with GI symptoms. So we had patients coming in with diarrhea. We had patients actually coming in with GI bleeding, with melena and hematochezia. And beside that, we had patients coming in with AKI, unknown AKI, that turned out to be massive rhabdomyolysis. We had patients coming in with strokes and DKAs, which were very weird compared to that. Now our threshold of testing is very low, so everybody who comes into the emergency room, he gets swabbed for the COVID, for the novel coronavirus. So, and then if they don't have pulmonary symptoms, then we search for any other organ. But mainly, as Dr. Saleem mentioned, there is a couple of tests that we order on admission. And I believe one of the important tests to order is CK, to make sure that you don't miss rhabdo, because if you don't test for it, you're going to miss it. To make sure to get good review system regarding the GI symptoms, myalgias is one thing that is very important, to make sure that we do a good neuro exam on presentation, or at least to make sure that we make regular neuro checks. During the hospitalization of a couple of patients, we have noticed that they had an acute stroke while in-house. They were on aspirin, they were on subcutaneous Lovenox, prophylactic Lovenox, and they had massive infarcts in-house. We believe also this is secondary to the hypercoagulable state. They are more of a thrombotic rather than embolic strokes. And that's what Dr. Saleem has mentioned is mostly secondary to the hypercoagulable state in this disease. We had also seen a couple of patients with diabetic ketoacidosis. That's new to them, that they were not diagnosed with that before. So this is also something to keep in mind. But they tend to pass out of the DKA faster than the usual patients, as far as the patients that I have seen. The rhabdo part also is pretty unique. So people who don't have pulmonary symptoms, they tend to get those, if we can mention them, as an extra pulmonary symptoms. So we had a couple of patients who developed AKI. We had a patient her creatinine reached 10, which was on admission, her creatinine was normal. And her CK peaked at, I believe, around 12,000. Just with hydration and supportive therapy, her CK normalized, and her creatinine normalized. Also, the GI symptoms, now we tend to see more people coming just presenting with diarrhea and nausea and vomiting. These patients tend to have less of pulmonary manifestations. They are not hypoxic in presentation, but the nasopharyngeal swab tests positive for COVID. So these are mostly the patients that we should keep an eye on. Also, we had patients who developed STEMIs while in-house. And this is one of the most important things not to miss, because the patients have chest pain because of the cough or chest tightness because of the hypoxia. So if they complain of chest tightness, it can be easily overlooked because they already have the dyspnea secondary to the hypoxia. So if you're not looking for it, if you don't take a good note and you don't do an EKG at that time, then few hours later or a day later, you'll end up with a massive STEMIs. And we have seen a couple of patients who developed in-house STEMI, and they were also on prophylactic anticoagulation. And I believe we just had a STEMI again today for one of the patients. So that's something to keep an eye on.
Okay, so just one thing, because you just said something that's a little bit tricky. So I have heard that in COVID patients, those patients will come with fever, tachycardia, and all the picture of sepsis, but they said that you don't give liberal amount of fluids as per the prior sepsis guidelines. But now, if you have a patient with rhabdomyolysis, usually with rhabdomyolysis, the core of treatment is IV fluids. So how would you manage a patient with COVID and rhabdomyolysis?
So this is very, it's a very delicate management of the disease, because if you give them a lot of fluid, some people think that they tend to go into acute pulmonary edema, and you will never know which is it from the extra fluid that you gave, or it's from progression of their underlying lung disease. So what we did is we carefully give them just gentle hydration from 50 to 75 cc normal saline per hour, and then follow regularly their oxygen saturation with accurate documentation every 6 hours, and we follow their urine output, and we follow their lung exams. So if we do chest X-ray every 3 days. So if the chest X-ray is showing signs of fluid overload, their clinical exam is showing signs of fluid overload with crackles, and if we find that their urine output is increasing, then we tend to continue the current management, because we think that the rhabdo is clearing, which is kind of challenging. You have to very carefully manage them. But if the urine output is decreasing and they are clearly in signs of fluid overload, then we hold the fluids, because this is most likely the fluid is making the condition worse. So it's basically, if it's going to be in a nutshell, you give them gentle hydration, not liberal hydration like the usual rhabdomyolysis, and you follow them every 3 days with a chest X-ray. You follow them every 6 to 8 hours, the pulse oximetry, and with clinical exam every day.
Okay.
And you follow the urine output.
Okay. Before I go to Dr. Alaa, I will ask you just one question, because it came back, one of the audience. So do you stay in the hospital for like 1 week or 14 days like what they do in Egypt, or you just return home every day?
Okay, so there is so one thing very important for the physicians in Egypt in general. That's more of a preparation step rather than an actual therapeutic thing, is that first, the hospital has to be prepared for the COVID patients. Everybody in the system has to be prepared and to know exactly what their role is. And then they have to have very good support among each other and among the hospital system. So in a simple way, I will say what happened and what we gained out of the experience. So first thing, when there is a surge of patients, everyone has to be very well educated in what to do with COVID patients, from the physicians, the nurses, the workers, the patient transporters, everybody. They have to know exactly what they are going to, because we had a gush of patients that came suddenly. People got scared. It's a human behavior. And people were afraid, and they were not, and they need to be trained. So if people get scared in the patient transport, and you end up with half of your manpower in the transportation division, they call out sick, or they actually get sick, your hospital can shut down. If, like, let's say that half of the patients in half of your lab technicians get infected, or they get scared and they call out, your hospital can shut down, and that's something that's not medical. So that's one of the things that they really need to address, and they have to prepare the personnel mentally and scientifically. For the healthcare personnel, one of the things that we did in the first place, and that's made us more convenient, is the dress code. It might sound off the topic, but it's really important for them to wear something comfortable during their work hours. A lot of people got scared because of when they come back to their homes, to their families, they are afraid of infecting their families. Maybe they have a sick father or a mother or a sick son at home, and these things pose a lot of mental stress on the work personnel, and it should not be overlooked, because you might think that you will lose those people as your manpower. So we made everybody here is just wearing comfortable scrubs from the scrub machine, and that's from the chair of the division till the resident, the nurses, even the transporters, so that they change it on a daily basis, so that they don't get scared when they go back to their homes. If we had a place near our emergency room, the way that we operate is that the patient comes either by an ambulance or just walk in. They had a triage tent on the door of the emergency room. If a patient has symptoms suggestive of COVID, they go this way. If not, they go the other way, so that they don't mix patients. And then from the emergency room, usually in the beginning, there was an area with the PPEs, the gowns, gloves, the masks were available. But then we improved that later on by making a special area of donning and doffing of the PPE, which I believe that the hospitals in Egypt can start doing that. They have a small room at the beginning of, or in an area near the emergency room, where they can wear their gowns, their gloves, and then they go to the emergency room, examine their patient, and then they go upstairs. The same goes if they are just in the inpatient ward. They have a separate room when they wear their protective gowns, gloves, masks, and then they go and examine the patient, and then they go back to their area where they're going to work, write their orders, and do their patient care, their patient documentation. It's very, very hard to wear the N95 mask and the gown for a long time. It's gonna drain the energy, and if a surge happens, like the surge that we had, I think it might be even impossible to work continuously with wearing the gown, the N95, the mask on for a very long time. The third or fourth thing is that besides that's of a more clinical thing related to management of the patients. The most important thing in pulmonary COVID is their oxygen saturation. So everybody should have a pulse oximeter in hand. So pulse oximeter is more important than the stethoscope during our times. So because when the patient, the saturation is 80, 90, the stethoscope doesn't differentiate. Even if their saturation is 95%, they still have crackles on their lung exam. But the oxygen saturation is actually the thing that will change your management, whether you're gonna prone him, whether you're gonna be giving him oxygen through non-rebreather, or you're gonna give him, or you're gonna put him on non-invasive ventilation or mechanical intubation. The last thing to say is proning. Early proning as soon as possible. If you recognize the patient and his oxygen saturation and requirements are high, then the best thing is to start proning and to start early on. We start proning even from the emergency room. So before even admitting the patient, the early on that you start them on the proning, the better the prognosis would be. That's pretty much it.
Okay, so I will leave you to enter the page, and then I will come to Dr. Alaa. So are you with me, Dr. Alaa?
Yes. Hi,
okay. Okay, so I need, because you were experienced in the ICU, because you spent almost 2 months in the ICU. So please, the first thing I need every doctor in Egypt to know, I need you to tell me about the experience when you get the patient, first, directly from the emergency room. Second, when you get the patient as a consult on the floor. Third, when a patient comes as an RRT. So RRT means rapid response team. It means like when you have a patient on the regular floor and then the patient start crashing. Then they call the ICU and the ICU come maybe to intubate the patient, maybe he has a cardiac arrest. So whatever, I need you to tell me exactly what did you do in the ICU. I need you to tell me the experience about the monitors, the experience about the IV drips, and what did you invent for the IV drips and the tubing and all that.
Okay. Bismillah ar-Rahman ar-Rahim. My name is Alaa. Second year residency. So it's I think the most common presentation ICU point of view is the maybe four conditions: either severe hypoxemia requiring intubation, cardiac arrest at home because of the hypoxia, stroke. Some of them came with a stroke, and DKA and acute renal failure. I think this is the most common presentation. You see numbers you never see before, like creatinine of 23 for a patient without any kidney history, potassium of 9. That's the most common presentation. So it's not only a ventilator issue, it's gonna need also dialysis. So everybody should think of dialysis options, dialysis facility, shyly access, nephrology doctor also should be on board. So this is very common. So our ICU capacity was like 16 bed in the hospital, and on the surge, on a daily basis, we had like 55, 53 patients ICU. So it was not easy, and almost like half of them was in the ED under ICU service because there was no beds. So it was a tough time. I hope Egypt doesn't get this surge. We pray for Egypt.
How did you manage? Like, tell us exactly the experience. So you have an ICU that have a 16 bed capacity, and now you are confronted with 55 patients, 55. So it's like more than 3 times the capacity. How can the hospital manage such a problem? Because the doctors in Egypt need to be prepared. What did you do?
So our hospital did 3 ICU teams, and we divided the teams regarding the geographic distribution of the patient in the hospital. So there was one team responsible for the actual ICU beds patients, and the second team was responsible for the floor ICU patient, and the third one was responsible for the ED ICU patient, emergency. So that make a big difference when you increase the personnel.
Okay, so the first thing that you increase the personnel, and there was a team caring for each service during the geographic location. So what did you, what was the difference in the prognosis for patients who are in the ICU service and they are on the floors, and ICU service on the ED and ICU service in the ICU? Was there a difference in prognosis?
Yeah, there was a difference in prognosis, and in the ED, when the surge was peaking, it was so hard, you cannot even, you don't have even space to move. So it was very hard. Your job basically tried to keep the patient alive until he either transferred to another facility or go up to the ICU, because you cannot even do the extubation and the weaning trial that much there. So it's hard. Even sometimes we had shortage of even the drips, pumping machines. So you have to deal with that also. That's basic. It's not easy, but with support of all, the most important thing is the teamwork actually in this crisis.
Okay. And tell us about the anticoagulation, because Omar was just talking now, and he mentioned about the anticoagulation, the prognosis in the ICU. And he said, I will need to listen to the input from Alaa. So what happened to the patient after starting anticoagulation, and what are the anticoagulation triggers and the monitoring for the patients in the ICU?
I'll tell you something, that once you put the central line or the Shiley for the dialysis and the ED, you feel it's already clogged. So those patients like very high coagulable. And yeah, so we start most of them even before the labs come for anticoagulation. Just check INR and APTT, and there's no contraindication, and platelet, of course. And if there is no contraindication, sometimes we start the heparin drip even before the D-dimer result. And then if it's normal D-dimer, you can discontinue. Some if it's attending ICU, attending prefer Eliquis, but the majority was with heparin because sometimes you need another procedure. You never know what will happen to ICU, so it's easier to shut down the heparin.
Okay, so heparin drip, how many percent like of the patients are on heparin drip, and how much are on like Lovenox? No, Lovenox is enoxaparin for everyone to know, and how much are like on heparin drip? Like what's the difference? And apixaban and all that.
I think majority on the heparin drip. I would say maybe 20% on Lovenox if the kidney function is good, which is rare in this disease in the ICU service. Once he's in the ICU, most of the time he has already AKI at least.
Did you see any difference in prognosis between patients on like the heparin drip and on Lovenox? Which one did better?
No, I didn't see any difference. No.
Okay, that's excellent. And how about the tubing? Because I heard that like nurses did something with the tubing that doctors here need to know.
Regarding what?
The extension of the tubing and putting the pumps outside and all that.
Oh, so they're putting the pump outside the room, yeah, to minimize the exposure. You can adjust the drips without entering the room. That's a good thing we do, yeah.
Okay.
But the other, yeah, I heard you asking about how the resident also get exposed. Sometimes you just rush, like sometimes you have a code or RRT, so you have to be careful when you go to wear the PPE. That's a very important. Also, you do chest compression, and there is secretion everywhere, so you have to be careful.
Okay, so there was a discussion, I remember, in one of the WhatsApp groups regarding the CPR in COVID patients. So tell me about your experience, because in the Queen's Hospital, you had 3,000 patients. Did you have any patient that had a code and you had successful CPR and like had a good outcome? Yes or no?
Most of the patients that coded, it's a very bad sign in COVID. I don't think it's there's like you can keep him alive for days after the code, but I didn't see any coming back.
Because
It's very hard.
because the problem is like the people were discussing whether they need to like announce like a DNR status for patient with the COVID, because the risk of getting infection while the doctors are doing the CPR may be more than the possibility that this patient may return. So maybe like
Yeah.
CPR will cause more harm. So when the nurse announces the code, you already are like wearing what while working in the ICU, because that's important.
Yeah, so you have to be prepared. Most of the time, we're already wearing the N95 and the surgical mask on top and the face shield and the hair cover. This usually we always the whole shift wearing this, and then before going to the room, you have to wear the gown and the gloves.
Okay, so you are wearing the face mask and the N95 during the whole 12-hour shift.
Yeah, most of the time, yeah, unless you're eating or something.
Okay, so that's important. That's for the residents and the interns. And what do the nurses do?
Yeah, most of them they're doing the same because there's no time. While in the ICUs, the patient can crash anytime, so there's no time to look for a mask or look for the face shield. So
Okay, so I will come back to you again. I will just return to Omar and then come back to you like with a few questions that they are asking. Dr. Omar?
Yes.
So this is very important because we had a big discussion regarding CPR, and I have seen your photo in the New York Times while doing the CPR. So tell me about the CPR experience, because that's very important that every doctor here in Egypt needs to know.
Yeah, I think that's a very important concept. I know initially there was, so we've gone through different in the past 3 months different phases of how we do the CPR. This is different for patients in the emergency room, different for patients on the floor, and different for patients on the in the ICU. I know on the floor, we, as chief residents, we created a system to basically minimize exposure for our medical teams and the personnel. So essentially what that meant is that we would have only one person from the ICU. If this was on the floor, only one person from the ICU, one admitting person a responding person to the room, and also the medical team of the patient. Only those people would go into the room for the code, or also for an RRT. Most of these patients who come in with COVID, the reason for their RRT or rapid response is desaturation. So most of those patients end up being intubated during that time. If there was an RRT, we discussed with our administration the importance of having anesthesiologists there, because in these patients, if you have too many, you want to minimize attempts for intubation. If you and you want to minimize the time that the patient has or the medical personnel have in that room, because that just increases your risk. Many of our two of our residents who were involved in intubations got sick, and a lot of the respiratory therapists who do the intubations at the hospital here, they also got sick because they were attempting multiple times. So now the system, the way that it works is that we have the anesthesiologist, we call them first to try the intubation so that it's done quickly. Now, as far as running the CPR, first we minimize the number of people there. The second thing would be that is also there's a reality of this disease. Like Dr. Alaa was saying, the prognosis after CPR is very, very poor. So we have to make sure that we communicate with the families, and also to to the benefit of the patient too, because you don't want to put them through too much. So with the cycles of CPR that we run are not as many as you would do on other people, because it's the outcome is poor in general. So that was one thing. The other thing we did. Now the third thing is, if the patient goes and we're doing CPR in the ICU, now our policy is we don't take them off the respirator to bag them. The patient stays on the respirator. This minimizes the respiratory therapist being exposed because of the aerosolization from, and also makes sure that the person who's doing compressions, he's not being exposed either. So that's the other thing we do. As far as the CPR cycle, we follow the ACLS protocol. It's the same. The one thing though, like Dr. Mohanad has said, that because they come in with so many renal problems, and we make sure to supplement that. Now, usually, like, they have a lot of patients have severe hyperkalemia that you don't normally see, and this can happen within a day. And so we like giving calcium gluconate or giving sodium bicarb. Those things play an important role, but at the same time, you have to realize the reality of the disease as well, and that's another important thing.
Okay. So I have I will ask you like 2 questions and then shift to Mohanad and then shift to Alaa, because that's the question that the audience are asking. So one question by Dr. Amgad Azabi is asking, did you see acute hepatitis as the picture of COVID-19?
Yes. I think one thing that Mohanad has spoken to is that this infection has a multi-organ picture. You see the pulmonary signs because the pulmonary signs are the most visible to you, with the cough and things like that, because that is something that inherently is a visible quality. But when you look at the labs, you see a multi-organ picture, and almost I would say 80% of the patients come in with hepatitis transaminitis.
Sorry, I got a call from the attendant.
Oh, okay. So yeah, so we do so for the people who are getting tocilizumab, we do a hepatitis panel in all those patients before we start the medication, just to make sure that there is no history of viral hepatitis, but there is a transaminitis that is present.
Okay. And did you do any plasmapheresis for any patient?
We have not. No, not so far.
Okay. Did you give IVIG for any patient?
I think so, but Alaa might know. I'm not sure. I don't think so on the floors, but he might know better for the ICU. But I don't believe so.
Okay. Okay. Mohanad, Dr. Mohanad.
Yes.
So another question from Dr. Zainab Azam. She's asking, on what basis is massive screening done, and what type of tests? So what are the tests that you do for screening, and what is the basis of testing?
So for the hepatitis part, there is usually there is transaminitis with the COVID, but from the ambulatory side and the inpatient side, that my experience, maybe Alaa can talk about the MICU part. The highest AST/ALTs that I've seen was like 700, 800. Haven't seen anything in the thousands. But the challenging part would be that there is, beside the transaminitis that comes with the disease itself, there could be transaminitis from the azithromycin, from the ceftriaxone, and from the hydroxychloroquine, and even more from the combination of the 3 of them. So we had a couple of patients who had higher transaminitis, so we tried to stop one of the therapies and then continue with the other. So let's say that the most potent that we would think would be the hydroxychloroquine and azithromycin. Then if we see that there's the LFTs are getting up, then we stop the ceftriaxone. And then if it continues to trend up, then we stop the azithromycin. And then the last one we stop would be the hydroxychloroquine. If it still trends up, then we think more that there is something else going on beside that. But as Omar said, in the beginning, we send for hepatitis markers for everybody, just to make sure. And I believe in Egypt, this would be even, it would make more sense because of the high prevalence of HCV.
About the screening tests.
The screening test, when we had the surge, we presumed that everybody coming in with any viral-like symptoms has COVID, and which actually ended up most likely true. So anybody with cough and fever, we presume that he has COVID. Anybody coming with GI symptoms, most likely he had COVID. And then when we reached our peak of the surge and the ER was extremely busy, then everybody was exposed to a COVID patient, whether the patient beside him or the patient walking into the ER with him. So he's exposed one way or the other. So we just ended up swabbing everybody, and we did the PCR nasopharyngeal swab for the novel coronavirus too.
Okay. Did you give any IVIG or do any plasmapheresis?
We didn't do IVIG or plasma exchange for anybody here.
Okay. So Dr. Alaa, are you with me now?
Yes, doctor. Yes.
Okay. So the next question is for you because you were in the ICU at that time. So how often did you prescribe pulse steroids like methylprednisolone, Solimodrol?
So I would say maybe 99% was given steroid on the ICU. So the routine admitting order was, unless there's no contraindication, was the azithromycin and Plaquenil, the anticoagulation and the steroid. This is the bottom line, unless there's any contraindication.
So the steroids were in the beginning with the surge or like all through, and whether like the steroids plus anticoagulation affected the prognosis?
No, in the beginning of the surge, actually, there was debate to give steroid or not in the ICU. I think it took us like 7 to 10 days, and then everybody was on steroid after that.
Okay, and how is the prognosis different now? Like last 10 days, when you started giving pulse steroids and you started giving anticoagulation, how are the patients doing?
So it's hard to tell the prognosis from which other medication or the vent management or the experience that we got. We don't know this. I think the prognosis is becoming better. Was a higher extubation. In the beginning was extubation very hard. Now we have percentage of extubation, and but we don't know which is which. What's the reason for that? It's hard to tell.
Because you started a lot of things at the same time.
And also we became more experienced, so you don't know.
And what is the dose of
Even
the steroids?
So the steroid, either you use the Solimodrol, it's by kilogram, or the dexamethasone 20 for 5 days, and then 10 for 5 days. But it depends who's the ICU attending. Some of them prefer dexamethasone, the other prefer Solimodrol. So
you use Solimodrol at what dose? 2 milligram per kg or higher or lower?
No, it's 1 milligram per kg, I think. Yeah.
Okay.
Like
okay.
Yeah, but so some people give it 1 dose, but most of the people divide it now. Like if for example, if it's 100 kilogram, you give like 40 every 8 hours.
Okay. And then
also there's a very important, I'm sorry, I just want to say something. There's a very important issue on the floor, especially. Just make sure, especially this happening at night, because the patient need the oxygen, right? It's a primary hypoxemia disease. So it's happened a lot, RRTs and code, that the patient go to the bathroom at night and he coded because the oxygen was not on his face. So just be aware of that the patient need the oxygen 24 hours.
Okay, so I guess Mohanad already called me and told me this. So this needs to be addressed, like, and every doctor in Egypt needs to know this information that just Alaa mentioned. He said that a lot of patients died at night because when they are on oxygen mask and the mask falls down when they are asleep, they just die. They don't say I am dyspneic or whatever, like they just die, right?
Yeah.
Okay.
They just go, that's it.
Yeah, so they don't get short of breath or call for the nurse. If your patient at night, the mask falls off, he dies. That's it. So beware of that. So did you see any like GI bleeding in the ICU? Because a lot of doctors are asking about the GI bleeding.
Yeah, we saw most of the complication. We saw pneumothorax because of the high PEEP, and we saw bleeding GI. We saw intracranial. We saw bilateral pneumothorax, hemothorax.
I have like a few gastroenterologists that they are interested to know the outcome. So did you do an endoscopy or colonoscopy for those patients with GI
Yes.
bleeding? Yeah,
Yes.
and what was the result?
Just recently, the patient was presented by cardiac arrest, and on admission, the hemoglobin was 3, and it turned out she has a AVM on the colon. She's still stable. Like this was 1 week ago.
Okay, so she had AV malformation. Okay.
Yeah.
The other people, did they get like any stress ulcers? Like, did they have
No,
anything abnormal?
you don't know also this is a stress ulcer or this is because of the very high anticoagulation. Some people develop retroperitoneal hemorrhage. It's very hard balance, it's delicate.
So that's why maybe we need the heparin drip so that can be stopped early. Okay.
Yeah, and as per the Mount Sinai papers, the heparin actually is anti-inflammatory also. So.
Okay, because we were just discussing that, whether like it's anti. Do you have experience with pediatrics in the hospital? That's a question that one. Okay, so we don't have.
The youngest patient we dealt with was 18-year-old.
Okay, okay. Thank you, Dr. Alaa. So I will return again to Dr. Mohanad.
No problem.
Are you with me? Dr. Mohanad is not with me. Dr. Omar? Dr. Omar?
Yes, I'm here.
Yeah, okay. So I will ask you just a few questions because that's what the audience are asking. You are the star now. I saw you in the New York Times, so you need to answer this. Okay. Dr. Mirvat is asking, could asymptomatic carrier be a super spreader? And is the runny nose and sneezing early symptoms? So what do you think?
Asymptomatic carriers, I think we don't see as many in the inpatient side. I think that would be more on the ambulatory side, but we have had, this is more maybe anecdotal and in terms of our medical staff, but we probably have many asymptomatic carriers just from experience. But as far as spreaders, I don't think we know too much about it. I think that's more on the ambulatory side and testing outside.
Okay. And like the runny nose, was it like a common symptom?
Not too common, actually. It was very interesting. Initially, we were comparing it to a very similar presentation like the flu, like influenza. But at the same time, there weren't many who came in with runny nose. It was more just shortness of breath and cough. And not many with like the congestion, sneezing. Those you wouldn't see much, actually.
Okay. And what do you think is the percentage of the patient presenting with atypical symptoms?
Oh, many. I'd say at least 60%, 70%. They would have, like Mohanad had spoken, he said they would have your typical symptoms, but also extra pulmonary complaints. So there are many patients who came in with shortness of breath, with cough, but at the same time they would say, they would have melena, GI bleed, they would have nausea, decreased appetite. So I would say those people were probably 70%, 70 to 80%. And then there'd be a 20% group that was just completely atypical, where they would have no pulmonary complaints, but they would complain of they would have come in with GI bleed, or they would come in with GI symptoms like nausea, vomiting, or diarrhea.
So 2 questions. For those patients who are coming with GI symptoms, are they febrile, and what was the CT findings?
Some were febrile, and the CT would actually not show anything. CT was non-specific most of the time. I had 2 patients with GI bleed with melena, and the CT findings were just non-specific, no signs of any gastroenteritis or any kind of colitis, and they would just have the bleed with no past medical history of bleeding either.
And the lungs were fine?
The lungs of those patients, it varied. I had 2 patients who were fine, but also 2 patients who had the bilateral infiltrates. So it varies significantly. And I think that's the one thing with this is that you can never rule it out as COVID responsible for it, because the variety of symptoms are significant.
Okay, thank you, Dr. Omar. Dr. Mohanad, are you with me now? Dr. Mohanad? Okay, I think you have a problem. So I'll come back. Dr. Alaa, are you with me? Dr. Alaa?
Hello?
Yes. So
I just want to comment something for the gastroenteritis. So it's a very common presentation that you have GI symptoms, but at the same time, the CAT scan accidentally, when you do the abdominal CAT scan, the base of the lungs will show bilateral infiltrate, like was done 99% of the patient.
Okay. So then there is an important thing, because I was asked this question before. So if a patient comes with GI symptoms and you do the CAT scan, you have pulmonary findings in the CAT scan. But
yes,
when you do the PCR for COVID, the respiratory tract, will it be positive or it will be negative?
No, most of the time was positive.
Okay. So it will be positive also. So another question, doctors in the ED, how do they rest from the PPE, or they are wearing the PPE all the time?
All the time.
Okay. In the emergency room, they are wearing it all the time. They don't take it off.
No, because you have the donning and room outside, just next to the ED. So once you're in the ED, you're wearing everything.
Okay. So how long do you think the patient should be hospitalized? Like patient with COVID, how long do they stay in the hospital? In average?
I would think the average was like 7 days without ICU. ICU is much more.
Okay, the average is 7 days. And did you see any autoimmune manifestations with COVID?
It's hard to tell because you have the cytokine storm, right? So you don't know what is going on there.
Okay. So,
but like I said, it's typical presentation for ICU, very typical presentation. Unknown diabetic, they come with DKA.
Okay.
And also at the same time for DKA, you need the fluid, right? And at the same time, you want to do the ARDS protocol with limited fluid.
Was it the vent setting that you used?
So the vent setting, in the beginning, before the paper from Italy came with the L phenotype and H phenotype, before that, everybody was high PEEP, like 20. Now we're trying to do a little bit protective, like maybe 10. You up titrator as much as you can.
Okay. Thank you, Dr. Alaa. Dr. Mohanad, are you with me now?
Yes. Sorry about that.
Oh, no problem. So I have a question. Autoimmune manifestations and thrombocytopenia. So how do you comment on that? Did you see that with COVID patients?
Yes, the majority of the COVID patients actually come with thrombocytopenia. But from so my experience was there, I've been on the floors from the beginning of the surge till a few days ago. All the patients were in the medical floors. They had a little bit low platelets, not marked thrombocytopenia. The lowest platelets that I've seen, maybe around 90,000, didn't go less than that. The majority of them goes between 100 to 120,000. But I have rarely seen patients with thrombocytosis. Maybe they just in the reactive phase. Sometimes a couple of patients have maybe around 450, 500, but these were very, very few patients. But the majority of the patients, I would say maybe 50 to 70%, they have a little bit thrombocytopenia with platelet ranges between 100,000 to 120 or 125,000.
Okay.
The coagulopathy that we have seen, we're trying to send the hypercoagulable workup for more patients to get an idea of what's going on, but we have seen patients who are the antiphospholipid. This was also reported in the New England Journal of Medicine in the 3 cases from China. The cardiolipin was positive. This we have seen in we can say in a lot of patients so far that was tested for this antibody. I'm not sure if there is any pathogenesis leading to the hypercoagulability, but that's something to be of note. I know that this test is extremely expensive in Egypt. With a one test, I believe, just one antibody, I think is for 500, 600 Egyptian pounds. But this is something to keep in mind.
Okay, so I will ask you a few questions and answer fast because like here it's getting late. Did you try using colchicine with patients?
No, in our hospital, I'm not sure if anybody has tried. Maybe Omar and Alaa can.
Okay.
No, not that I know of.
Okay. Did you do any antibody testing in your hospital?
No, the antibody testing will come to our hospital next week, so we haven't done it yet.
Did you send
But
any
we have
lactoferrin testing?
no,
Someone is asking.
No, but we started giving convalescent plasma to a couple of patients. We will see their outcome. We have so far, I believe, 3 or 4 patients. This is something new. We started yesterday also. I think 2 patients were just enrolled in the Mayo Clinic trial. So this we will see their outcome.
Okay, and regarding the HIV patients, so you have like 1,000 patients of HIV in the hospital. Did they come and present with COVID or no? Did you see any HIV in COVID?
I personally haven't seen patients with HIV.
I had 2 patients who had who presented, although they had mild symptoms. Yeah.
Okay, because that's an important question, Omar, because the thing is, they were saying that the HIV medicines had already an effect on the COVID. So that's why they were interested to know whether they presented similarly or they had mild symptoms. So you think that they had mild symptoms, HIV?
Yeah, actually, well, there was, from my knowledge, and also on night float, so the 2 people I had on my team had mild symptoms. They had come in. The one patient who actually, there's another patient we actually were covering on the nights, and he was HIV positive. But however, he was not compliant with his medications, and his viral load was high, CD4 was low, so he had a severe infection. He actually, I believe, he ended up in the ICU. And that was the only one who I know who was sick. The other one was mild.
How much is the percentage of patients presenting with lymphopenia? How common is lymphopenia in your opinion?
Mohanad or me?
Oh, yeah. So lymphopenia is very common. Very, very, very common.
Like
we don't have
50, 70?
Well, we don't have an exact number, but I believe that I have rarely seen a COVID with normal lymphocytes. Most of the COVID patients, I would say maybe 80% of the COVID patients that we've seen have lymphopenia. And Omar and Osman can also, and Alaa can correct me, and it has been also shown to be a prognostic factor. So we see people who are improving, their lymphocyte count actually is improving too. So it's for diagnosis and for prognosis too.
Okay, so someone is asking, Dr. Yasmin is asking about chloroquine for prophylaxis. Have you used prophylaxis for healthcare worker?
We haven't used anything for prophylaxis. The University of Minnesota had a trial for giving hydroxychloroquine. They were enrolling people, but from our experience we didn't have anybody on that I'm aware of who had hydroxychloroquine.
Okay. Did you send stool PCR?
Or chloroquine.
Did you send stool testing for COVID or in any patient or no?
Hello.
Hello.
Yes, I can hear you now. I'm sorry, there was a problem with the connection.
Okay.
Okay.
So that's the main thing, is just to be prepared for the medical personnel if they run short. So that's something that they should be prepared. Also, people who have underlying disease in the consultant or in the administration, also they should be maybe protected, because this disease has a very, very bad outcome, and it's not something that they should be like shamed of or something, but it's just a disease. If someone has any underlying medical disease, they should be excused, or they should have something to protect them.
So I'm sorry, when I got disconnected, I think I lost many of the questions, but I will ask you like now a question by Dr. Rima Al-Misiri. She's asking about mortalities among healthcare workers. So I know Ms. John, who else died of the disease at your hospital?
I'm not sure if I believe that she was the only one.
Okay, so only one nurse that died.
Yeah. But a lot of people were sick.
Okay. So question for Dr. Omar. I think this will be the last one because we have to finish. Dr. Omar, percentage of autoimmune diseases, and did you do any bone marrow biopsy for the patients?
No, to my knowledge, we have not done any bone marrow biopsy. The percentage of autoimmune diseases who present, that's a very interesting question. I personally, so going through all the patients that we've been admitting, we haven't seen many on that have a history of autoimmune disease, and it's very far and few in between that we see people who have any kind of autoimmune who end up admitted. The other point to this, I think, just going back to, I think this ties in with anticoagulation as well, is patients who come in on anticoagulation as well. We don't see as many of them have as severe of a case. Those who have, who are on either, especially Coumadin, who were on Coumadin before, we haven't been admitting too many people who are like that. They usually are their saturation is good. They're clinically good.
We just admitted one patient on Coumadin. His INR is 23 with COVID.
Okay.
Okay, so just like we will finish in 3 minutes. So I need every one of you like to tell me like one advice in 1 minute for the doctors in Egypt. So Dr. Alaa, please start with the ICU. How to manage, what advice in 1 minute for all the doctors in Egypt?
So first thing, protect yourself, because you're in the ICU. You need to be prepared for action, procedures, and codes. So I would stay wearing the stuff as much as you can, and also try to don't be nervous, relax, because it's hard anyway. So don't make it hard on yourself. And teamwork, like I said, you need teamwork. That's the bottom line.
Dr. Omar, advice in 1 minute.
Sure. I think one thing, especially on the floors, what Dr. Alaa said, and on top of that, just these patients require close observation, especially on the floors is where you can really save them. When they are intubated after that, their chances of survival drop significantly. So close monitoring on the floor is very important, and just be wary that anything is in the differential with them. You just have to be keep your eyes open to any slight marker or anything like that. and just keep your mind open to them too.
Okay, thank you. Dr. Mohanad, last piece of advice.
So this is a different disease. It's a new disease. It needs a custom-made management. Each patient is different. Like what Omar just said, you have to be very mindful of everything going on. Patients with pulmonary symptoms, their key is their oxygen saturation. The pulse oximeter is everything for you. You have to keep checking their oxygen saturation. That's your guide in getting better or getting worse. Always look for the differentials and change your management. And as Alaa said, initially we were swayed by the ARDS protocol. Now we're not. Initially we were thinking no steroids. Now we're not. So customized management, that's the best thing in management of patients with COVID.
Okay, thank you everyone. Thank you, Dr. Mohanad. Thank you, Dr. Alaa. Thank you, Dr. Omar. And I hope that this was helpful for all the doctors in Egypt. And we will meet again shortly, inshallah, in the next days. And Ramadan Mubarak for everyone. Thank you.
Ramadan Mubarak.
Assalamu alaikum.